The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome back to Sky Women's Health. Today, I'm thrilled to welcome back Dana Gibbs, Dr. Dana Gibbs. As you may remember her from episode 129. If you're newer to the podcast, you probably don't, but we did a great conversation around being stressed about stress, where we talked about chronic stress, cortisol, and how stress impacts your hormone balance. Dr. Gibbs is an ENT with a special interest in thyroid and hormone health. And today, we're building on that conversation, diving into Hashimoto's and thyroid disorders and perimenopause, and how hormone therapy can affect thyroid management, because for so many women, the line between menopause, perimenopausal symptoms, and thyroid symptoms is anything but clear. Welcome, Dr. Gibbs.
Hi, thank you so much for having me back. It's great to see you again.
Yes, you as well. And, last time we kind of dove deep into what's going on with the stress and thyroid disorders. I would love for you to kind of brief us on how you've led to this. I mean, this is like your second generation of your career, correct?
Yes, absolutely. So yeah, I started out as a general ENT in Arlington, Texas, and I trained very quickly in allergy because I figured out, you come to Texas and you realize that all sinus surgery doesn't fix everybody. So I very quickly had to learn how to do allergy shots and allergy treatment for people. And as I was doing that, I met a whole bunch of doctors who kind of do some out of the box thinking. They were kind of old time, pre the discovery of IgE allergists. And they did a lot of techniques that have kind of been lost to time and evidence-based medicine. But basically what I learned from them was a bit of out of the box thinking. And so I was in my practice and I was taking out thyroid nodules for people who came in, the endocrinologist or their primary care would refer them. Hey, you've got a thyroid nodule. It looks like it's suspicious. We should take it out. And they would come for their post-op appointments and they would gain 20 pounds, maybe 40 pounds. They would be tired. Their hair's falling out. Their skin is dry and itchy. They're constipated. They feel like crap. And I would be like, hey, you went and got thyroid medicine, right? And I'm like, and their endocrinologist didn't give them any. They said, your TSH is fine. You don't need it. Go away. And I'm like, what? You are clearly not fine. What's going on here? And it was funny because I remember at the time, I'd been in an academic institution taking out the baddest of the bad thyroid cancers and all that kind of stuff. And so all my pathology kept coming back, chronic lymphocytic thyroiditis. And I'm like, what the heck? And I had to go and look it up and figure out, back to the textbooks. What is this chronic lymphocytic thyroiditis? And I was like, well, okay, that's Hashimoto's disease. Oh, wait. Hashimoto's disease is an autoimmune disease. Why am I taking out people's thyroids for an autoimmune disease? That's not how you treat autoimmune disease. You know what I'm saying? It was this shocker to me. It's like, is this the only way we have to treat autoimmune disease? And I went and I looked up what the standard treatment for this was. And it was wait until your thyroid basically craps out and you have no thyroid hormone anymore. And then we'll give you some. That was the sum total. And that was 20 years ago. And
Yeah,
guess what the treatment
revolutionary.
is
Yeah.
today? It's the same. It's
Oh,
no difference. If you look in the guidelines, well, the guidelines are now 14 years old. I mean, they're old now. But the treatment of Hashimoto's autoimmune thyroiditis in mainstream medicine has not
has not
changed.
advanced.
It has not advanced, not one bit.
Wow.
And I was getting
But
ready
you
to
had a
swear
special
because it makes
interest
me
in
mad.
this. Yeah, yeah. But if I remember correctly, you have a really special interest in this because of your own struggle with
Oh,
thyroid.
yes. Well, okay. So about 5 years into practice, I went back to that same allergy group, to the out of the cowboys that I had been learning from. And I was like, you know what? I've heard this lecture before. Let me go across the hall into this other lecture. They're talking about hormones. And I'm like, I've got hormones. I'm interested in this. And I sat down in that lecture, and the dude started talking about thyroid. And he put up a slide that had about 16 different symptoms on it. And I had like 14 out of those 16 symptoms. And I was like,
Sure.
holy cow.
Yeah.
I didn't learn this in medical school.
Right.
And then he said something that really blew my mind. He said, and you don't have to have high TSH for this to be a problem for you. And taking Armour Thyroid will fix it. And I'm like, what? And so I went right to my GYN was my primary care at the time. I went right home to my GYN and I said, can I please try this? And within a week, I was a different person. It was like, I can get out of bed without hitting the snooze. As a matter of fact, I don't have to set the alarm anymore. I wake up when I want to wake up and I feel energy and I get out of bed.
Yeah.
That was not my experience ever before.
For that. So let's talk about those key
Yeah. I mean, it was like, okay, he knows what he's talking about, but he couldn't tell me why. And so I'm like, okay, now I got to go and find out why. And so I finally found another mentor. Strangely enough, he's also an ENT. And he was the one who taught me why and what to do and how to consistently get results for those people. And so in my practice, when they would come back and they would complain, I'd be like, hey, can I do some labs on you? Would it be okay if I take over checking your thyroid? And so I started doing that. And the more I did that, the more people started coming. And the more people came, the less room I had in my surgery schedule to, and eventually it got to where I was like, okay, I have to pick something. I have to pick one or the other. They had either do surgery or I have to go and do this other thing. And the other thing won. And so now I do the hormone stuff full time. And the funnier thing was, as my patients who were on thyroid medicine and on allergy shots and whatever got older and got into the perimenopause, menopause, they're like, can't you write menopause hormones? And I'm like, no, I'm an ENT. I can't do that. Can't do that. Can't do that.
Don't know that.
Well, now that I'm in my own practice, screw that. I went and got Menopause Society certified. And so I can do all of it now. And the interesting thing is it's all connected. It's all related.
Connected.
It's all
Yeah.
controlled by the same part of your brain.
Yeah. So let's talk
And
about that today.
So everything connects with everything else.
Yeah, absolutely. Let's talk about those key symptoms that often overlap with perimenopause, where, when patients come in with their symptoms, I'm always like, okay, yes, there's no lab level that's going to define you as being perimenopausal. There's no lab that says, oh, you're perimenopausal. But we do have to rule out underlying causes that can
Yes.
masquerade as perimenopause. So let's
Yes.
talk about those overlapping symptoms.
Sure. So the overlapping symptoms tend to be mood changes, brain fog, hair loss or hair thinning, irregular periods. I mean, it's just about weight gain. Oh yeah, weight gain. It's just about every symptom. I mean, there are a couple that are really fairly specific for hypothyroidism or okay, I even have to do a definition here because mainstream medicine says hypothyroidism means your TSH is low. I'm sorry, your TSH is high and your T4 is low. I kind of broaden that out and I say, okay, you can be, euthyroid, but still sick from thyroid hormone. And euthyroid meaning those 2 lab tests are normal. And I can find the imbalance on some other lab tests that I order. We can talk more about those after a while if you want to. But if somebody has this autoimmune disease, Hashimoto's disease, very, very, very frequently, they will start having symptoms of their thyroid being off way before those 2 blood tests go abnormal.
Yeah, so
And
let's talk about what Hashimoto's thyroiditis is
yeah,
and how it progresses over time.
yeah. So Hashimoto's thyroiditis is an autoimmune disease similar to rheumatoid arthritis or lupus or all those others, but it primarily damages your thyroid gland. And it comes on when your body, there's a bunch of factors that make it come on, but having genetics is about 70% of it. If you have a family member who has an autoimmune thyroid disease, you're about 70% susceptible to it. And then stress is almost, that it's funny that we talked about stress last time, because stress is very, very universal in um, the onset of Hashimoto's thyroid disease, and in particular, perimenopause and pregnancy and postpartum. And those are the times when it's the most likely to come on, but it can start when you're a kid, it can start when you're a teen, and you don't even realize it until 20 years later when your thyroid levels completely go away. Or it can start making you have symptoms right away. Um, and and so sometimes we will find it, like I was talking to somebody earlier this weekend who was about 9 months postpartum, and they're like, I feel like, dog meat, I'm not breastfeeding anymore, so that isn't it, blah blah blah. And I'm like, yeah, I think you have Hashimoto's disease. So Hashimoto's also affects other parts of your body. I mean, it's an inflammatory process, so it can make you have joint aching, and it can make you have this brain fog that people talk about. And if they do measurements, they find inflammation in brain, and they find antibody evidence inside your brain. And so it's like, okay, it's not just attacking your thyroid, but so many of the symptoms that come with it are worsened by these imbalances that you get in your thyroid, even before that TSH gets abnormal.
So it's important that we get the proper diagnosis. And you're
Uh-huh.
talking about how sometimes that general thyroid panel doesn't tell the whole story.
Right.
Let's talk about what is needed for a proper diagnosis of common thyroid disorders in
Yeah.
perimenopause. Because as you were mentioning, Hashimoto's thyroiditis, which leads to an overactive thyroid and eventually an underactive, versus pure hypothyroidism. I
Right.
don't know if you want to define those
Sure. Yeah,
separately, but
absolutely.
some imaging is needed. So I wanted to kind of go through all of that.
Sure. So, about 15% of Americans will test positive for the antibodies of Hashimoto's disease. That doesn't mean you have Hashimoto's disease. So if you have those antibodies and you have no symptoms and you feel fine, and all your rest of your thyroid labs are normal, and your thyroid gland is not, inflamed or swollen or whatever, then we don't call that Hashimoto's disease. But it's kind of a fine line, and it kind of depends on who you talk to. Because if you talk to the endocrinologist, they'll say, oh, well, you don't have it unless you actually have a nodule that's big enough that we need to biopsy. Or you don't have it unless it's damaged your thyroid to the point where we want to give you levothyroxine. And so I look at it and I see the positive antibodies, and people don't come to me when they're not having symptoms. I mean, I don't get people who are just like, oh, I gained 15 pounds, I want to get checked. They're like, I'm so tired, I can't get off the couch in the mornings.
Right, right. But the weight gain is also a huge thing in perimenopause. Like they can't stand
It
it. That's what brings
absolutely
through
is.
the doors a lot
So
of times.
so the fatigue being the number one symptom a lot of times is a red flag to me that there's thyroid issues playing a role. But if you've got somebody who's over 35 and they start having those symptoms and it's not associated with a pregnancy event, it still could be perimenopause. Because I mean, like when I got pregnant, I was a high risk late pregnancy kind of girl. So I think you almost always have to think both.
Yeah,
I
absolutely.
really do. I
So
mean,
what labs are we going to
yes,
get to rule out what's going on?
yeah. I mean, every woman is going to eventually get to perimenopause. Not everybody has thyroid antibodies, and but if you have enough of the symptoms and you get worked up and you go on hormones and it doesn't help you feel better and your hair's still thin and blah blah blah, it's like dig deeper on the thyroid, because there's definitely nothing that says you can't have both at the same time.
So what labs or imaging should we be getting?
So you first of all, just a good hands-on thyroid exam from your doctor. And it's funny, people don't even know where their thyroid is in their neck, and they put their fingers up under the corners of their jaw and they touch those glands that are there and they think that's their thyroid, and it's really not. The way you find your thyroid is you put your fingers in the V of your collarbone, right in the center of your neck, and then go off to the sides. And so if your doctor did not touch you on the sides of your windpipe right above your collarbones, they didn't check your thyroid.
This is a part of my comprehensive annual exam for every patient.
Yes, and it should be. It absolutely should be. I'm glad to hear that you do that.
Mm.
And so you feel that area. And if you feel the thyroid, like if you can feel it, if it feels firm under your fingers, that's almost always abnormal. And if you feel a lump that moves up and down when you swallow, then that is definitely abnormal. And that would absolutely, in my opinion, warrant a sonogram, and sometimes even a biopsy, depending on how big that lump happens to be. Thyroid cancer is a real thing. It's not rare, but it's not super common. But, it happens often enough that it's important, if you have a lump in your thyroid area, that it gets checked out for sure. But a lot of lumps, I would say 90 to 95% of lumps are benign, and almost all of them are caused by Hashimoto's disease. And so it's really, really important. When this is something that I really tried to do when I was doing surgery, which is, let's make really sure that we need to take out part of your thyroid before we do it.
Yeah. Yeah,
Because
as
I
fun as
see
operating
people,
is, it's gotta be
yeah,
the right procedure for the
well,
right
I
person.
see
Yeah.
people come in and they're like, I have a lump, I'm worried it's cancer, I want you to take it out. And I'm like, do you understand the implications
Yeah.
of what happens when half of your thyroid is gone? And they don't. And so that I spend a lot of time explaining that thyroid hormone is kind of like it's the gas, it's the fuel for your body, it's the raw energy that we need to build new proteins, to build muscle, to grow hair, to make your skin supple, to make your GI tract move. I mean, like I have a friend, this is a weird and very sad story. I have a friend who had Hashimoto's disease, some time ago, and her GI tract basically stopped working. And she had constipation so terrible that her doctors finally convinced her to have her colon removed.
Oh my gosh.
And it was her thyroid.
Mm.
It was, what a horrible thing to realize that, we just missed that, you know? And so it's really important that they have really great modern testing called Afirma testing that you do when you do a needle biopsy of somebody's thyroid. If they have a lump in their thyroid and you do a needle test, this Afirma test it's not super cheap, but you can ask for them to basically do a genetic test on the biopsy specimen, and it will tell you whether or not it's cancer or not, basically. And the reason I encourage people with Hashimoto's looking nodules to do that is because it's easy to mistake Hashimoto's disease for cancer on a needle test. And then you get the final specimen back and they're like, oh, well, it was benign. And I'm like, you just had half your thyroid taken out for no reason. And more likely than not, you're going to be accelerated in the now you need to be on thyroid hormone for the rest of your life.
Yeah.
Which is not the end of the world, but it's not ideal either.
Yeah. So I want us to talk about what lab work you want to get done.
Okay. So the first ones that are the screening that everybody gets, right, regardless of whether they say, I feel crappy, I feel great, the screening is the TSH test. That's
Yeah,
the
it's
first
usually a
one.
TSH with reflex to T4 if it's
Right.
abnormal. So we're
And
really only looking at that thyroid stimulating hormone.
right. So thyroid stimulating hormone is from your pituitary gland. So if the pituitary is the thermostat,
Also the same organ that produces FSH, follicular stimulating hormone.
correct, exactly. The same organ that produces FSH and the same organ that produces ACTH, which is the stimulator of stress hormone. So yeah, all the controls are right there in that one place. And so if one goes wrong, sometimes they all go wrong at the same time. But anyway, so TSH is the hormone that tells your thyroid, hey, it's time to speed up. It's not thyroid hormone. TSH is a pituitary hormone that signals, hey, body, we need more thyroid hormone. And that does not start going abnormal until 75% of your thyroid function is gone.
Whoa. Okay.
Yeah. And so it's a very late indicator that things are going wrong. And so I like to see the free T3 and the free T4. And those two hormones, the free T3, I like to see it in the upper half of the normal range. If somebody says to me, I'm tired, and their T3 is below 3, which is about halfway up the normal range, I believe them. And I say, you know what? I think this could be related to your thyroid. If their T4 is very high, that's okay. If it's low, it's okay, as long as the T3 is in a good spot. And then the final test that I do, and I do this on everybody because everybody that comes to me, I'm highly suspicious that something's going wrong. And so I do a ratio of total T3 and reverse T3. And maybe I need to explain to you what those two things are, because T4 is the inactivated hormone as it comes out of your thyroid gland. And it gets made by enzyme, gets converted by enzymes in various tissues in your body. It gets converted to either T3, which is the active hormone that you need. That's the fuel to the fire. Or it gets made into reverse T3, which is kind of like the sludge that clogs up your fuel injectors, or I don't know. But it's not helpful. But it's also a signal that your body is trying to inactivate your thyroid hormone. And that's very, very common to see in people with Hashimoto's disease. And I don't really know why that is. It has to do maybe with the inflammation that's going on all through your body, or it has to do with the fact that your hormone levels will fluctuate because the immune damage fluctuates. The attack on your thyroid hormone gland will come in and attack, and your thyroid hormone will go up, and then it'll go down, and then it'll go up, and you're down. And because high hormone levels in your body are so dangerous, hyperthyroidism is, emergency room time. It's dangerous. It causes, rapid heartbeat, sweating, convulsions. It's very, very dangerous. So your body has lots of checks and balances to make sure that doesn't happen. And one of them is this thing called reverse T3. And reverse T3 is inactivating T4 to something that your body can't use, but it also, the same enzyme that does that, inactivates T3 and takes it down to the next step on the chain, which is T2. And so if you have high reverse T3, it indicates that you are inactivating your thyroid hormone. And that's a big red flag to me, that those symptoms that you have are related to your thyroid and that we need to work really hard to get those under control.
And then thyroid antibodies, of course, you've already
And then, of course,
mentioned
the thyroid
those.
antibodies.
Yeah.
And by the time people see me, most of them have already done that test. But if they have not, then I will absolutely order a thyroid peroxidase antibody and a thyroglobulin antibody. And people get mixed up with this because there is another test called thyroglobulin. And thyroglobulin is a protein that's in your thyroid hormone. And if you have a thyroid, then you have thyroglobulin protein. Usually it doesn't get spewed out into your blood system. Usually it stays in the thyroid gland. So they use thyroglobulin testing to check for thyroid cancer. Kind of the way they use CEA. There's other proteins in your body that we use for serum cancer markers. Well, thyroglobulin protein is cancer marker. Thyroglobulin antibody is Hashimoto's or autoimmune thyroid disease.
So let's talk about thyroid management during perimenopause and how the thyroid function naturally changes during perimenopause, why some symptoms may worsen or change during the hormonal transition.
Right. Well, so earlier I was talking about periods of stress being a time of onset for Hashimoto's disease, that it
Yeah,
can
and
trigger it.
perimenopause definitely is a time of
It can
stress.
it triggers it, and it's a time of stress. But why is it a time of stress? It's a time of stress because your estrogen is fluctuating so much. It's going up to 400, it's going down to 20. It's all over the place. And that in and of itself is a stressor on your body. Whether or not you have any mood changes at all, that is a stressor on your body. And that is a trigger for about 50% of the people who get Hashimoto's. That's when they get it. The other half are like if you have mono is a very insidious virus. You get it when you're a teenager and it's like, oh, you're sick for a couple weeks and you feel fine. And instead of going away, it goes dormant in your system. And anytime you get super stressed, it can get reactivated. And there is some thought that that reactivation can trigger the autoimmune attack in people. But pregnancy, once again, big stressor. Postpartum, what's going on in postpartum? Well, your hormones are going crazy again. They go from super high to now maybe really, really low, depending on how long you breastfeed for. They can go almost completely away. Your body sort of thinks you're in menopause, but it's just pumping out nutrients for your baby. And then as you go back out of that breastfeeding thing, then your estrogen starts coming up and starts fluctuating before it kind of settles down and goes back to normal again, normal cycles. Um, that's another big stressor on your body. And it seems like those are the two times when people really have either the onset and or the reactivation of Hashimoto's. And then the third time is when people get pregnant. A lot of times that's the first thing people will check. It's like, oh, your TSH is elevated. Why is your TSH elevated? And then they do the antibodies and they're like, oh, well, you have Hashimoto's disease. And they find that out either when they can't have a baby or they're trying to have a baby, or when they're early in their pregnancy, they find it. So very, very almost, it's tightly wound in with women's health and reproductive
Sure,
health
sure.
so that you can't just about separate it.
Yeah, so there's some common pitfalls in misattributing thyroid symptoms to perimenopause or menopause or vice versa. So
Mhm.
obviously there's a role for lifestyle, right? Managing diet, stress,
Yes.
sleep,
Yes.
exercise. As always, I feel like that one is like on repeat
That's
in my
all that
practice.
stuff is so foundational. It's so
Yes. So
foundational.
foundational for all the things, for all the things.
Yeah,
But let's talk about how estrogen, progesterone, other hormone therapies can affect thyroid hormone levels. So, for
sure.
an example, estrogen increasing thyroid binding globulin? Is it going to affect their thyroid treatment?
Yes,
So
absolutely.
that's something that I hear often, but
Yes.
is it true for transdermal estrogen or is it just oral estrogen?
No, it's true for transdermal as well. Anything that's a systemic estradiol product is going to do that, and vice versa. So if somebody is in menopause and they're on hormone replacement and I start them on thyroid hormone, it raises their thyroid binding globulin, which also raises their sex hormone binding globulin. And now all of a sudden their estradiol prescription is not strong enough anymore. And so then they have to go and adjust it. And vice versa, if you start somebody on estradiol and they were stable on their thyroid hormone, then they might not be after you do that change. And so it's like you play this little seesaw balancing game to get it right. And it's not always as simple as people hope it's going to be.
Yeah. Yeah. I mean, we definitely have to monitor symptoms, timing, labs.
Mhm.
Let's talk about timing of thyroid medication, uh,
Okay.
because I had a patient the other day who told me, "Oh, no, I take mine at night with a particular seltzer, and that's how my doctor's always had me take it." And I
Mhm.
just my jaw hit the floor because I've only ever been taught that we take our thyroid medication in the morning
In
on
the
an
morning,
anesthetic
yeah.
with
Well,
water only.
I'm gonna give you even another perspective, because I tell my patients to take their thyroid hormone twice a day.
Oh.
Um, and let's talk about the reason why I do that. So, because most of my patients are Hashimoto's disease, and most of them have this conversion problem. They don't make the active thyroid hormone in their body tissues as well as most people. If one of the things that worsens that problem is high doses of levothyroxine. Your your pituitary gland detects that high level and it'll pass it on to the brain. It converts it to T3, it passes it on to the brain. So your brain's maybe doing all right, but it tells the rest of the body, hey, we got enough. We don't need to make a lot of T3, and it turns it off. It does something called ubiquitinization of the enzymes that make T3. And so when I see people with that high reverse T3 marker, the first thing I say is, okay, let's divide your levothyroxine into two doses so that when you take it, you don't get as high of a bump as you were getting when you were taking it all at once during the day. So that's another thing that a lot of people don't really understand is, we doctors were taught, oh, levothyroxine has a half-life of 2 weeks, or, it's really actually more like 6 days, but that's steady state. That's if you were getting a slow IV infusion drip, or that's if you're counting on the thyroid hormone that's already in your body bound up to the proteins that carry it around 99.7% of it. When you take a pill of thyroid, if you were to go to the lab every hour for 24 hours, you would see the same dose response curve that you see with antibiotics or with every other medicine. It goes up, 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 down, 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 down. And, you get it to that steady state, but you're still getting that 3 hours after you take it, you're having quite high levels. And the way we have traditionally tested thyroid is that you go to the lab the next morning before you take your pill. And so you never see that spike, you never see that high, you only see the low. And if you don't go to the lab until 9 or 10 or 11, because that's when your doctor's appointment is, then not only are you seeing not the lowest point of the day, you're seeing several hours after your lowest point of the day. So you're seeing a sub trough level, which means you're totally missing the potentially overdosed medicine. And so one of the ways that I try to mitigate that is by having people do their medicine twice a day and then go to the lab exactly between the doses. So if you take your thyroid at 6 in the morning and 6 in the evening, then you go to the lab at noon. So you're halfway between. So I know on average where you are at any given time. not the highest, not the lowest. It's in between. And that helps. But what you were saying about taking levothyroxine at bedtime, there's a lot of people who only take levothyroxine and do absolutely fine. And if it feels better them to take it in the morning, then take it in the morning. But what I see is people get up, or they wake up in the morning and they're at the lowest level of the day on their thyroid hormone, and it makes it much, much harder to wake up. So if you take it right at bedtime, you go to sleep, and then you're kind of halfway through that down cycle by the time it's time to wake up in the morning. So you don't have as hard of a time waking up. And so a lot of people do find that that's helpful to take levothyroxine at bedtime. And if I had somebody who was only taking levothyroxine, I would be happy to let them do that.
So, let's talk about what the risks are of untreated or undertreated thyroid disease during hormone therapy.
Oh, wow. So once again, it kind of goes back to, what does thyroid do for you? Thyroid stimulates your metabolism. It helps set your basal metabolic rate, which is the rate at which you burn energy, even if all you do is lay around on the couch all day. It helps you rebuild your body's tissues. It helps your heart contract. It helps your GI tract contract. It helps your brain function. As a matter of fact, this is an interesting thing that I learned, is that thyroid conversion in your brain is so very protected that even if you have almost no iodine, like to where you're making so little thyroid hormone that your TSH is 75 or 100, you will still have preserved, all the thyroid hormone will be getting sent basically to your brain, because it's so key. And what happens to people who have had their thyroid removed and don't stay on their thyroid hormone is basically they become profoundly mentally impaired, profoundly depressed. They start retaining fluid. They deposit a bunch of lipopolysaccharides, or glycoproteins under their skin. They kind of swell up and have what's called myxedema, which is swelling in your face, swelling in your forearms, swelling on your legs and tibias. And eventually they die. I mean, it's not like type 1 diabetes, where if you don't have insulin, you're going to die in a week. But, it might take a year, but they're going to die. And so untreated hypothyroidism, especially if you get pregnant, if your baby is exposed to low thyroid levels while they are in utero, they will be profoundly mentally impaired, and sometimes just die. And that's the name of that is cretinism, when the baby is so hypothyroid. It's really quite dangerous. And it actually used to be, not that long ago in the United States, it actually used to be pretty common, not necessarily in Texas, but up in the upper Midwest, in the Mississippi Valley area, and out in like Eastern Oregon, Montana. There's an area up there where there's just not any iodine in the soil. And so people don't get it. But and that's one of the reasons why the United States made the decision to universally do iodized salt, because they decided it was too complicated to just supplement the areas of the country where iodine was so low. So they just did everybody. They said, okay, everybody gets iodized salt. That's the way it's sold now.
Yeah. Yeah.
And it was profoundly successful. There are counties in Ohio where they say that the IQ went up 30% on average. Wow. From before to after. And they know that because of military recruits that were from those areas. It's crazy.
Let's talk about how thyroid dosing might need adjustment when starting hormone therapy.
Yeah.
And then maybe signs that a patient may need their thyroid reevaluated during perimenopause.
Okay. So once again, I do this a little bit different than what a lot of people do. But I would say if you change doses on your menopausal hormones, then you should give it 3 months and then you should check your thyroid again. If you have a symptom change, either sudden or over a period of weeks or months, then I would definitely check again. And if you change your thyroid medicine, if I change somebody's thyroid medicine, what I always do is I will move up the next check, and I have patients who are stable and they come once a year. I have patients who are not quite so stable and I check them every 6 months. Hashimoto's tends to be less stable because the antibody attack can come and go depending on your stress level, depending on your inflammation level in your body. So I tend to check those folks every 6 months. If I change their thyroid medicine, then I want them to come back in 3 months and let me look at it again. And just make sure that everything's good. And then they can go back on that 6-month schedule.
Sure, sure. And sometimes this takes some coordination between the endocrinologist or the primary care and the OBGYN and or
Yes.
your menopause specialist if that happens to be someone else. So it can take a little bit of coordination, but all fatigue in perimenopause is not necessarily just menopause.
I
So
would, no, I think you're absolutely right about that. So if somebody comes to me and they say, Doc, I think I'm in perimenopause, and I'm like, okay, what's your number one, list your symptoms and give me your top 3. If number 1 is fatigue, I'm always suspicious of thyroid.
sure, sure.
I'm always more suspicious of thyroid if the number 1 symptom is fatigue. And then if it's fatigue and their hair is so thin that I can see their scalp through the top of their hair,
Yeah,
I'm like, lady, you got thyroid problems.
yeah,
I mean, I look at them and I go,
yeah,
I don't, it's not that I don't do the labs, but I know what I'm going to find.
yeah. So there's an emphasis on individualized care and knowing that it's not a one size fits all or just a TSH
Right.
that might
Well, I
reflect
mean,
or might not, right?
yeah, the other thing that, when something's more perimenopause is when it fluctuates every 6 to 8 weeks.
Sure, sure. There's some
If
sort of
you're like,
routine or
okay, yeah,
cycle.
there's, your cycle is not normal, but it's fluctuating with your cycle. I know that's perimenopause stuff.
Yeah, I mean, it's really common that we see like a worsening of PMS symptoms or a
Hmm.
prolonged period of PMS symptoms that wasn't happening before.
Yeah,
Whether
PMS,
patients are
migraines, joint pain.
right, right.
Gosh.
And that's when it's more perimenopause.
Hmm.
So I want our listeners to be encouraged that with thyroid management and hormone therapy, these symptoms can be very manageable with proper guidance, right? And so sometimes finding that particular physician or provider can be the crux because
Yes.
for so long we have been undertrained in menopause care. So,
Yes.
anyways, Dr. Gibbs, this has been a very detailed conversation. I hope that listeners have hung with us and really kind of digested this information because it's so meaty and I feel like it will help them to be better advocates for themselves if they're dealing with thyroid disorders.
Yeah.
Can you tell listeners where they can find you?
Sure. So my office is in Southlake, Texas, but I see almost 95% of my patients. I see them virtually after the first appointment. And like you, I have started using a membership model because I want people to be able to, it's like, hey, this happened. I want to know what this is. I'm like, okay, send me a text, send me a message. Let's talk about it and see if we need you to get new labs, need to come in. But yeah, I'm open. I have spots for new patients. And my website is danagibbsmd.com. You can find me there and we'd love to chat with you.
Easy peasy. Okay. Well,
Yeah.
thank you so much for joining us. Until next week, be well.